Hello, we will be starting the presentation in approximately 5 minutes. Thank you for joining us, and please stay on the line. For the best audio quality, use the dial-in number provided on the GoToWebinar reminder email. Good morning or good afternoon, depending on where you are joining us from today. My name is Julia Ann Love, and I would like to welcome you to today's webinar. I'm a partner and the practice group leader for the Employee Benefits and Executive Compensation Practice Group of Thompson Hine. I'm joined today by Thompson Hine partners Laura Ryan and Kim Wilcoxon and Senior Managing Associate Beth Mandel. Today, Laura, Beth, Kim, and I will wrap up our Consolidated Appropriations Act webinar series with a summary of lessons learned based on additional guidance received. Kim will discuss the upcoming prescription drug reporting requirements. Laura will discuss contracting issues relating to the prescription drug reporting. Beth will discuss recent guidance relating to surprise billing and other hot off the presses FAQ guidance and mental health parity and equity addition. Mental Health Parity and Addiction Equity Act update, and I'll wrap up with some reminders about what's next. To proactively address a question we frequently receive, today's webinar is being recorded and will be sent to all registrants within approximately 2 business days. During today's presentation, please feel free to use the question panel at the upper right-hand corner of your screen. We will answer questions at the end of the webinar as time permits. And now we will begin with today's program.
Thanks, Julia. This is Kim Wilcoxon, and as Julia mentioned, I'm going to talk about some questions we've received on prescription drug reporting. That's probably the largest amount of questions we've received, so we're going to spend the largest amount of today's program on this topic. Just as background, the Consolidated Appropriations Act created a new ongoing reporting requirement. So we're going to start this year, but it'll go on, indefinitely. The requirement, as many of these group health plan requirements apply both to health insurance issuers and group health plans. So the first deadline that we have to think about is this year, December 27th, 2022. So we're going to have to submit reports to CMS about certain prescription drug reporting information and additional information about your plan. Reports about the 2020 and 2021 years must be reported by December 27th of this year. And then reports for the 2022 and future years would be submitted on the June 1 following that year. Now, why do we have to submit this report? Because the government is going to take a look at this information, synthesize it, and then issue a public report based on data collected. The first report from HHS is due June 27th, 2024, so we have a little bit of time to wait, but reports are then going to be published biannually thereafter. Next slide. All right, so the government refers to this as the RxDC, or Prescription Drug Data Collection Report. And this report is submitted by uploading several files through the RxDC module in the Health Insurance Oversight System in the CMS portal. These may not be terms you're familiar with, but I bet you will be familiar with them here by the end of the year. Because the files may need to be submitted by you, the plan sponsor, through that system. Or they can be submitted by your insurer, your TPA, and or your PBM. Now, the files that are going to be submitted include plan files, which are specific to your plan, data files, which may be aggregated with other data, and a narrative file. And we'll get into all detail on those things here in just a moment. It's important to note that CMS has issued some filing instructions, and those instructions were updated at the end of June in a very helpful way that will allow us to sort of streamline how this information is provided to the government. So with that background, the biggest question we've been getting comes from employers with self-funded plans with carve-out PBMs. And they're saying the PBM is giving me two options. I can participate in the PBM's aggregate filing, or I can receive data from the PBM so I can submit the filing myself. What do I need to be thinking about when making this decision? Well, first, you need to understand what it is that needs to be done in order to complete the reporting. And you should know that a plan can complete the reporting by having different entities submit files on its behalf. So it's not all or nothing. It doesn't have to be all you or all your PBM. You can have different entities submitting these files. But multiple reporting entities shouldn't be submitting the same data for a plan, although entities can upload different narrative responses, which we'll get into in a minute. So what are the files that need to be submitted? As I mentioned, we'll have some plan files or some P files. Those P files provide information about your plan. As a group health plan, you really only need to submit the P2 file. The P1 or the P3 would not be applicable to your plan. Then we'll have data files or D files, and those files will provide specific information about your plan. Next slide. And then we'll have the narrative response file. So CMS is asking some questions, and I know this type is very small. We're not going to go through all of the questions here, but essentially they're going to ask you to write out answers to questions and submit them back to CMS to say, explain a little bit more, provide context around the data files that are submitted. Next slide. So where are you going to get the data to put into these files? Well, the P2 file, most likely your vendor may have a good chunk of this information. They'll probably be asking you for some of it. You also should have a good chunk of this information, but may need to ask your vendor for some data. Next slide. Here's where the updated reporting instructions actually become very, very helpful, because now under these new instructions, The D3 through D8 files are only asking for data about your prescription drug benefit, not any data about benefits that are provided under your medical benefit. So if you have a self-funded medical plan with a carve-out PBM, the data you need for D3 through D8 is going to come from your PBM. You don't need to have any sort of input from your TPA. You don't need to have any sort of input from any other vendors. Your PBM should have all of this data. The likely source of reporting data for the narrative files, to be honest, I'm not entirely sure. Some of this is going to come from the PBM. Some of this you may need from the TPA. Some of this you may have. It's worth, looking at the questions to understand. But I would say the PBM is not going to be able to submit your full narrative response file for you, but they should be able to submit some of the answers. Next slide. You should also know that if a vendor is going to be reporting on behalf of more than one plan, they have to aggregate their data and report it based on market segment and state. So for example, let's say, vendor number one is submitting data on your behalf. You are a large employer, self-funded plan based in Ohio. That vendor is then going to have to take all the data of all self-funded plans, of all large employers based in Ohio, add all those numbers together and report them together. And then they're going to need to report separately for the small employer self-funded plans based in Ohio. And then they're going to have to report separately for the self-funded large employers based in Indiana, and so on and so forth. So they are going to have to take all the data of all of their clients and then group it appropriately based on market segment and state. In addition, they're going to have to drill down on that data so that the data that's filed for a particular plan is not less granular, and I'm trying to think of the right way to say it, it's not less granular than how the plan is reporting the D2 file. I'll explain that a little bit more here in a minute. Next slide. So all of that being said, when your PBM is saying, do you want to be part of our submission or do you not? What should you be thinking about? Well, first, CMS is encouraging aggregate submissions. This is something they want. They don't want to get a whole bunch of different, reports from a whole bunch of different places because, again, they've got to synthesize all of this information and then, translate it into their report. So they want you to be part of the aggregate filing. That doesn't mean you have to. That's just the policy that the government is encouraging right now. You should also know that the PBM likely has all the data it needs to submit complete files for D3 through D8, excuse me. So when your PBM is asking you, do you want to be part of this? They should be able to take care of D3 through D8. Now, they may need data from you to complete the P2 file because they should be adding a P2 file for your plan to the D3 through D8 aggregate files that they're submitting. That P2 file is the way that the vendor tells the government that they are reporting on behalf of you. So they are going to need your EIN, your plan name, plan number, plan year end date, the name of your TPA, the EIN of your TPA, the number of members as of 12/31 of the reporting year, and the state in which your plan is offered. And here's the tricky part, because we've seen at least one PBM vendor, ask, what state is your plan offered in? And if it's offered in multiple states, tell us it's a national. That's not the right answer. The right answer is the state in which your plan is offered is the state in which your company has its principal place of business. So it's important when providing information to your vendor that when they ask what state your plan is in, it's the state in which your company has its principal place of business. Next slide. So here I mentioned the granularity. This is really interesting, I think, because the reporting instructions reflect the regulations, which say that the data submitted in files D1 and D3 through D8 can't be aggregated at a less granular level than the aggregation level used by the reporting entity that submitted the data in the D2 category. So let's say we have a carve-out PBM that's submitting files D3 through D8 on behalf of your plan. If you, plan sponsor, are submitting your D2 file on your own, you're reporting only on behalf of your plan. If that's the case, even though you're in the aggregate filing with the PBM should be separately reporting your plan data on a plan basis. I wonder if that's going to happen. If the PBM says to you, do you want to be part of our aggregate? My guess is they're aggregating all of the large employer self-funded clients in Ohio, and they're not asking, whether you're reporting D2 on a plan basis or via your TPA. That would be a question to ask your vendor. If we're reporting on our own, on our D2 file we're submitting, it's just our plan data, are you going to report our plan data separately? Now, if your TPA, your medical TPA, is going to be submitting the D2 file on your behalf, then the PBM needs to know that so that they can be reporting all of the large self-funded employer clients in Ohio with that TPA and aggregating all of that data together. All right, next slide. Now, let's say you say to the PBM, no thank you, I don't want to be part of your aggregate report, I want to submit my own. So give me my data so that I can submit my own file. If that's the case, the PBM should be providing you with data that's specific to your plan. They should not be providing you with aggregate data because you are reporting on behalf of your plan and only on behalf of your plan. So if you have anybody else's data in your report, it's wrong. If you opt out, is the PBM going to provide you plan-specific data? It's an excellent question. The better question is, can you do anything with that plan-specific data, right? Like, is getting that data and knowing what this information is about your particular plan, is that going to be helpful to you? If so, you may want to opt out, because then you could get that data that's specific to your plan. You could use it, have your consultant run numbers or what have you so that you can see trends. That may be a reason to opt out. If you're not going to do anything with the data, there may not be a reason for you to opt out of this aggregate filing. Now, if you will be submitting the files yourself, as I mentioned earlier, you are going to need to do so through the HIOS, through the CMS portal. So you'll need to establish an HIOS account. The instructions for that are available online. I think CMS has a nice website. If you just Google search, actually we're going to have a slide up here in a minute that gives you the website. But if you Google search CMS, prescription drug reporting, you should come up with their site that has instructions on reporting, how to register for the portal, how to use the portal. But they do say that establishing an account can take up to 2 weeks. So let's move on to question number 2. Let's say we had a change in PBM. We switched from PBM 1 to PBM 2 effective January 1, 2020. How will that switch impact my reporting? And then let's say instead of 2020, we switched in 2021. And the reason, obviously, we're using these dates is because 2020 and 2021 are the first reports that have to be submitted this year. Next slide. So if you changed 1/1/2020, your new PBM should have most, but not all of the data that you need to file for 2020 and 2021. And I say that because the 2020 report in the D5 file includes information about increases in spending. And so they're going to look at data from 2019 to determine the increases for 2020. So that file actually asks for prior year data and current year data. So the prior year data for the 2020 report will be 2019 data. So in this particular situation, you're going to need to get data from your old PBM. If you switched PBMs 2019 to 2020, that's a long time ago. I mean, do you still have a PBM who's willing to provide you this data from 2019? Hopefully the answer to that is yes. If not, then you will need to work through that.
Kim, can I ask here, can you confirm that the reporting, the years that we're reporting on are calendar years,
They are calendar
regardless of whether or not our plan year is not on a calendar
That's correct.
basis?
Yep, it's calendar year reporting.
And at least one service provider in one of their webinars suggested that if it was not possible for the plan to get 2019 data, that perhaps they could address that in the narrative file. Do you have any thoughts on that?
I don't, I've not thought about it, but
Okay.
it doesn't sound wrong.
Okay.
Right. I mean, and the narrative file really is, if you've got questions, if you need to explain, that's probably the place to do it. Yeah. So let's say you do have a vendor who is being very helpful and does provide you the data. There's one of two ways it can happen. Either PBM1 can include the 2020, oh, we moved on to the 2021 slide, but it's okay. The answer is the same, is old PBM can either report prior year data in its report, but not include current year data. So the old PBM will have your data in the current year, in the prior year column, but not the current year column. Or they can just give their data to you. You give it to your new PBM and they include it in their report. So either old PBM has prior year and new PBM has current year, or old PBM reports nothing and new PBM reports them both. Next slide. All right, let's say our PBM is willing to submit D3 through D8 files and part of the narrative response file on behalf of our plan, but our medical TPA is not willing to submit any files. What do I do? Well, as I mentioned, you're gonna need to do this yourself. I have not heard of any vendors out there who are willing to sort of take on this responsibility for you. I've not heard any consultants, raising their hands. We certainly are not raising our hands, at least not at this point, to do that. So you're going to need to do this yourself probably. And the way to do that is to obtain an HIOS account first. And so as you can see here in very teeny tiny type, we have the website for obtaining an HIOS account, instructions for doing that. You'll need to gather the necessary data, which we'll talk about in just a moment. And then you'll need to submit the files through the CMS portal. There are template files, so you can take a look at them and see what it is exactly you would need to provide and how would you need to do it. And then instructions for use of the portal are available online as well. So is this something that an employer actually can do? I think we've sort of looked at, if we got an Excel spreadsheet from a vendor, could we turn it into the kind of file? And I think we figured out that that would be not unreasonably difficult to do. So don't let this scare you. I think the scary part is figuring out who's going to give me the data, where is it going to come from, and can I make sure that it all gets to where it needs to go? So leading into our next question. Let's say our plan uses the following vendors. We have our medical TPA for self-funded medical plan administration, stop loss carrier who issues a stop loss policy, which is purchased by the employer, Msk Vendor. So we've got a vendor who provides a musculoskeletal health program for which the employer pays a fee per enrolled member. So the TPA, the medical TPA, does not administer claims. We're not sending claims to the medical plan. The Msk vendor is doing this as a flat fee per member. And then we have a wellness vendor who provides general wellness services for which the employer pays a PEPM fee, but the TPA does not administer claims. In that situation, what data does the plan need in order to complete the D1 and D2 files? And does the employer need data from all of these vendors in order to complete the files? Next slide. So the D1 file, this is the list of data that will need to be reported. So the issuer or TPA name and EIN, fairly straightforward. State, as we mentioned before, it's the state in which your company has its principal place of business. Market segment. Market segment is either for group health plans, small fully insured market, large fully insured market, small self-funded employer, or large self-funded employer. A large employer generally is one with over 50 employees. So that's how you know the difference between large and small.
And that is on a control group basis, right?
Right, right. The average monthly premium paid by members, the average monthly premium paid by employer. So that's information you're going to have. Life years. What is a life year? A life year, to calculate your life years, what you do is you determine the number of members, and that's belly buttons, covered lives, not just employees. Determine the number of members covered on a given day of each month. So for example, the first day of each month. You add all 12 of those numbers, and then you divide by 12. That's your number of life years to report. So again, that's not totally difficult to figure out. Premium equivalents. Basically, you can use your COBRA value, the COBRA premium minus the 2% surcharge, and then your ASO TPA fees paid and your stop loss premiums paid. For the D2 file, next slide, you're going to need information for different categories of spending. So for each category of spending, you need total spending, which is the total payments made under the plan to healthcare providers on behalf of members, the total cost sharing from the members, and amounts not applied to the deductible and or out-of-pocket maximum. So those spending categories are hospital, primary care, specialty care, other medical costs and services, medical benefit drugs, known amounts, and medical benefit drugs, estimated amounts. So when we think about the plan that we have with the vendors that we have, next slide. Obviously, we're going to need data from the TPA. The TPA is going to be able to give us a lot of the spending data. The stop loss carrier, we do need stop loss premiums in the file. Now, what we don't have is guidance to say, is there any difference between a stop loss policy that is a plan expense versus one that's purchased by the employer? You know, when you look at reporting on a Form 5500 for stop loss, you sort of look at, is this a plan asset? Is the stop loss policy issued to the plan? Is it issued to the employer? We don't have guidance to indicate whether there's any sort of difference there. So probably you can include the stop loss premiums in your total spending, regardless of whether it is included in your COBRA premium, paid by the employer. You know, additional guidance would be helpful. I doubt we're going to get it on this point. For the MSK vendor, remember that the employer is paying a fee per enrolled member. So for everybody who decides to be part of this program, we're going to pay, let's say, $99 for the year. Do we have to include that in the total spending for the other medical benefits? We don't know. We have no idea. Again, guidance would be helpful. I don't know if we're going to get it. Work with your advisors on this. You know, is the per enrolled member fee a payment made under the plan to healthcare providers on behalf of members? Sure sounds like it, but is that really what they're looking for? Uncertain. The next one, we do have certainty. Thank you to the June reporting instructions. We don't have to include the PEPM fee from the wellness vendor because the June reporting instructions say we only need to deal with wellness spending if it's reported as billed on a medical plan claim. So we have one easy answer. All right, now we get to another difficult one, which is multiple insurers and TPAs. Our plan includes the following options with no carve-out PBMs. We're not going to worry about the PBMs here. Let's say we have a self-funded option administered by TPA 1, another self-funded option administered by TPA 2. We have an insured Northern California option through Issuer 1, an insured Southern California option through Issuer 2, and an insured Hawaii option through Issuer 3. Can any or all of these entities file for my plan? Well, we remember that data has to be reported by market segment and state. So for your plan, you need to be reporting sort of data separately for the self-funded options. Now, your plan is obviously going to be the same employer with the same principal place of business. So it would seem that the two self-funded options need to be aggregated together because that's, you know, the same market segment, the same state. But we don't have guidance about what to do if you have multiple TPAs. Can each TPA report for you separately? Do you have to get data from both TPAs and aggregate it together and submit it on your own? Is one TPA willing to give data to the other TPA? This is a point of uncertainty at this point.
And Kim, does that same uncertainty exist in a slightly alternative design where, let's say you still just have one TPA for your self-insured medical, but let's say for some reason you have two PBMs, two different carve-out PBMs.
Exact same
question.
Yep.
Can each PBM submit their own separate files, or does the data need to be aggregated into a single data file?
If I read the reporting instructions technically, which I'm going to do on the next slide, I think we have to aggregate it. I think we have to get that data and submit it in one file. But it would be great if those reporting instructions were updated again to say that the PBMs could submit separately. But before we get to that slide, let's talk about these insured California options. Again, remember, we have to report by market segment and state. Both of these options are insured in California. So does that mean we have to get the data from both, just like with the self-funded TPAs, and aggregate them together? Well, here we have some guidance on multiple insurers. So the guidance that we have says if in-network and out-of-network benefits are provided by separate but affiliated insurers, you can combine the data or report separately, it's your choice. Well, that's not our situation here. It's not as though the in-network benefits are provided by Northern California and the out-of-network benefits are provided by Southern California, so that's really not going to apply. Guidance doesn't otherwise address affiliated issuers. But if the issuers are not affiliated, we know we do report it separately. So we don't have to aggregate it if those two issuers are not affiliated. And then, of course, we have our Insured Hawaii option, the data for which should be, reported on its own or aggregated with the other, insurer clients if the insurer is going to submit that. Okay, so here's where I get a little, uncomfortable, because the reporting instructions provide multiple reporting entities should not submit the same data file for a plan, issuer, or carrier. For example, a TPA and PBM should not both submit D2 for the same health plan. Well, we know we have to, aggregate this data separately by market segment and state. We know that insurance companies have an obligation to report. In our, situation here, could we maybe submit our own self-funded data, but then allow the insurance companies to submit a D2 file on behalf of our plan? I don't know. It says you can't submit D2, maybe should is the word here, should not both submit D2 for the same group health plan. But if, Hawaii is going to report our data no matter what, because it's their obligation to support a report, in addition to our plan's obligation to submit a report, how in the world does that happen if we don't if the government's not going to allow us to separate different reporting for the different options? I think this is another place of uncertainty and difficulty. And again, really hope that we get some updated instructions that just say, plan, don't worry about it. Let the insurance company do it for you, which Laura's going to get to in a minute, one way that you can get to that point. And that is a segue to turn over to Laura.
Let me, before I address the contracting points, we've gotten three questions that all sort of relate to the same concept. So one question is about how the reporting portal is going to recognize what's written down here as multi-employer plans, and I think that's being used in the concept of like a union-sponsored medical plan that's available to its, a variety of different employers that are otherwise required to, contribute or offer those programs. Another one asks about what about multiple employer plans? Not 100% sure. But multiple employer plans, we can have those types of entities within the context of a group health plan. And then also asking about what if you use the same TPA, but you offer different plan designs to different groups. And these really are getting at this question about what is a plan? What constitutes a plan? And I don't know if we have very clear guidance or definition on that really kind of preliminary point in all of this.
And that's a question that we've asked, is an option a plan? Is an ERISA 501 plan the plan? That it would be great to get guidance on that question.
But right now, it's very unclear, I'd say,
it is
how a multi-employer plan.
But even if you have one plan that has, two different options, a high deductible health plan option and a PPO option, I got the sense from reading the directions that data had to be aggregated, one TPA, one PBM, you just have two different options. I think that data has to be aggregated.
I think that, like I said, based on what we know now, I think that's right.
But when you get into the question of multi-employer plans and multiple employer plans, my guess would be you throw that to the plan sponsor and you act like, well, you're really the insurer in this situation. And if I was advising a client that had one of those, I'd be certainly, when Laura gets to the contract amendments, I'd be sending something to them too and say, hey, multi-employer plan sponsor, I think this is on you. Can you tell me that you're going to do this on my behalf? And maybe that satisfies good faith compliance and I did my best to get it done, and in lack of other guidance, that's as good as anything. I don't know.
And there might be something in the instructions, I'm just not recalling, on those types of plans. I don't have any of them as clients, so I didn't focus on it, but it might be there. It's worth a look.
And Kim, this is sort of a separate question, but in situations where we have the TPA filing aggregate reports for D3 through D8 on behalf of a plan, plan is separately filing D2, how are the agencies going to link up those reports?
The P2 file. So the P2, every file that's submitted on behalf of your plan should have a P2 file that has plan identifying information. So if you submit D1 and D2, you'll submit it with a P2 file. When your vendor submits the D3 through D8, they'll submit it with a P2 file that has your information.
Yeah, and I would caution everyone that's listening. That's something you may have to push back on your vendors on, because I've heard numerous presentations where they say we're only submitting D through D8, and we are not going to submit P2 on your behalf.
So the P2 file, if you look at the template, it not only has, the plan information, but then there's a whole list of, are you submitting D1? Are you submitting D2? Are you submitting? So that's the way of the PBM saying, okay, here's the plan information, yes to D3 through D8, but not D1 or D2. And that's how the government says, oh, well then there should be a D1 and D2 file somewhere out in the universe. Let's go find that.
All right. So let's move on to contract amendments. My vendors will not enter into contract amendments for prescription drug reporting. What are the risks? So I think in answering this question, it's important to keep in mind that for the most part, these prescription drug reporting requirements apply to the plan. They don't apply directly to the providers, to the PBMs, to the TPAs. It's the plan's obligation to file these, to submit these files. Now, the guidance does recognize that third parties can submit these files on behalf of a plan, but there needs to be a written agreement in place in order for that submission to be able to be done by a third party on behalf of the plan. I think in our experience, third parties have been hesitant, resistant to putting anything in contracts regarding the obligations that they are undertaking as it relates to these files. Sure, they send emails, they say in the emails what they're planning to do, but, an email typically is not going to have the same level of binding, authority and force that a contract amendment would have. And so, there is some risk here if the vendors don't do this on your behalf, or don't do it, correctly, or at least in accordance with a good faith interpretation of existing guidance. And I think from a practical perspective, it's worthwhile because there are some, there are penalties, whether or not they're going to be enforced at this stage based on the open questions that exist with respect to the reporting is a whole nother question. But there are the potential for penalties to be assessed in the event these reporting requirements are not met. But I think more important than that is the fact that what Kim mentioned at the very start of this is an ongoing requirement. And I think, plan sponsors need to be thinking about what happens if I make changes in the future. The reporting, is going to be done after the fact. It's going to be done in the year following the year to which the data relates. And if you decide,
sometimes 2 years, because you need the retro year.
Exactly. And so I think you need to be thinking about your exposure and risk. As long as that vendor remains your vendor, they're probably going to cooperate here and do something to help you comply with these requirements. But the minute they cease to be your vendor, big question mark about how helpful they will be as it relates to reporting that will be getting done in a year when they're no longer your vendor. So I think that's one thing to keep in mind in terms of, why you need to continue to push to document, and especially if you anticipate that there's going to be a change, let's say in these third-party administrators or PBMs in 2023. You absolutely want to nail down the current vendor as it relates to what they're going to be doing to help you with the reporting associated with 2022. In addition, to the extent that any of the vendors are going to be charging a fee for this reporting, I think that's a leverage point. I think, you use that as an opportunity to say, fine, you're going to charge a fee. We're going to amend the contract to specify what that new fee is. And in addition, we're going to be very clear on what services are being provided in exchange for that fee. On the point about making changes, I would also suggest that you utilize that as a leverage point for prospective contract amendments. If you're awarding business to a new vendor, that's the perfect opportunity to insist that in order for them to, win your business, they're going to agree to clearly outline in the contract, what obligations with respect to prescription drug reporting or all the other, new requirements that our prior webinars have discussed and covered, which has also been our experience. None of the vendors are willing to document in the contract any of those obligations. But awarding new business to a new vendor is always a great leverage point and opportunity to ensure there's a clear outline of what's going to be provided by the TPA. I mean, it's not going to fix anything retroactive. I think those are the main. There is on the duplication of effort slide. This talks about in the case of fully insured coverages, there's actually the ability to sort of shift ultimate responsibility for this reporting to an insurer, but again, that's conditioned on the plan sponsor entering into a written agreement with the insurer.
And with the TPA, if we had to hang our hat on that email being the written agreement, I think we have a decent argument. With this duplication of effort thing, though, it says under which the issuer agrees to provide the information in compliance with this section, right? So if the issuer says, oh yeah, we'll do it, don't worry. But the issuer is not going to say, they're never going to volunteer, we will do it in a manner that complies with this thing on your behalf. So whereas I think we could hang our hat on just an email notification, not that it's great, but if we had to make an argument, I think it's going to be more difficult to make that type of argument from just a notification from an insurance company.
One other question, just to close this out, because I know we're going to move on to a couple other topics and come back to a couple other topics besides prescription drug. Question, do you know if retiree-only plans are required to submit the data files to do the prescription drug?
They're not.
Okay.
All right. So we have some additional recent guidance that's come out in the last week, actually, related to the No Surprises Act and some of the transparency regulation requirements. The first piece of guidance that came out relates to the independent dispute resolution process, the arbitration process involved with respect to surprise billing. It gets into a lot of detail about specific processes involved in that dispute resolution process, probably at a level that most of the people on this call are not really getting in the weeds with, you're not really going to be concerned with. But if you do have questions about that process, this guidance does provide some additional information, and any one of us or your other advisors can help you walk through that process. And then a little bit more probably interesting to some of the people on this call, we did get some recent FAQs on Friday that again address surprise billing protections and various other issues. Highlights from these FAQs include they did clarify that surprise billing protections for emergency services, non-emergency services furnished by a non-participating provider at a participating facility, and air ambulance services apply to plans even if that plan generally provides no coverage for out-of-network services. So it's not a defense or you can't get out of those protections by virtue of the fact that you generally just don't cover anything out of network. Now you're going to have to start covering services out of network in certain cases where, you know, if you are providing any emergency services, you're going to have to start covering out-of-network emergency services that fall under the surprise billing protections. If you are covering air ambulance services when provided by a participating provider, you're going to have to start covering air ambulance services if they're performed or provided by a non-participating provider to the extent they would be covered under the plan if they were obtained from a participating provider. We got some additional clarification with respect to scope of emergency services. So with respect to air ambulance services for emergencies, the No Surprises Act does not require plans to cover air ambulance services for non-emergent care if the plan otherwise would not cover non-emergent care for if it was received from a participating provider. And then surprise billing protections apply to air ambulance services involving a point of pickup outside of the United States, as long as the air ambulance provider is licensed under an applicable state and federal law. So if somebody gets injured while on vacation and there's an air ambulance provider that's licensed in Texas who goes to pick that individual up in Mexico, that claim is going to be subject to the No Surprises Act protections. We also got some additional guidance related to the application of surprise billing protections as relate to plans that don't have networks. So plans that involve or use reference-based pricing. That probably doesn't apply to most of the folks on the call, but reference-based pricing arrangements are sort of on the rise. So just wanted to mention that. There is pretty decent guidance in these FAQs relating to those types of plans. We also got additional information about calculating the QPA in various scenarios, provider payment and IDR process situations, application of surprise billing protections to emergency services furnished at behavioral health care facilities. In general, you know, not going to go into detail about a lot of those. The behavioral health crisis facility is somewhat interesting because I think it just brings to the forefront again the fact that the agencies are not applying a narrow reading of these requirements. So if somebody is receiving emergency services at a behavioral health crisis facility, even if that facility isn't licensed, you know, quote unquote, as a emergency facility or as a, as a quote unquote hospital, it's likely that the surprise billing protections are still going to apply to that behavioral health crisis facility. All right, let's see. Additional highlights of this guidance. So we did get some guidance about the disclosure requirements, both related to the surprise billing notice and the machine readable files. It's a little late because we, have already passed the deadlines for making sure that those notices and those machine readable files are posted. And this gets back to the discussion that we were just having about contracting and the difficulty in getting contracting in place sometimes and getting these contract amendments. But in general, this additional guidance does basically address situations where there is a group health plan, and the group health plan does not have its own public website, which is the case for most group health plans. So if you do not have a separate public website for your group health plan, with respect to the surprise billing notice, the plan can satisfy the notice requirement by entering into a written agreement under which the plan's health insurance issuer or third-party administrator posts the information on the public website of the insurer or the TPA, where information is normally made available to participants, beneficiaries, and enrollees on the plan's behalf. In this case, both self-insured and insured plans ultimately are going to retain responsibility if there is any non-compliance. So this is not a case where you can, shift that liability to the TPA or insurer by entering into a written contract. Sponsors have to ultimately still ensure that the TPA or insurer is actually posting that notice. Otherwise, you have risk. I do also just want to call out that there was a revised model surprise billing notice that was issued prior to this guidance coming out. So if you go online now and you look for the model surprise billing notice, you'll see that the document actually has two notices in it. It has a notice that is approved for use for the 2022 plan year only. And then there's a notice that is approved for use beginning 2022 and in later plan years. That second notice has to be used starting no later than plans that begin 1/1/2023 or after. So if you are still using the notice that initially came out, you're going to want to switch to that new notice before 2023 so that you can retain the good faith compliance.
Let's just say as employers are getting ready for open enrollment, do you think this is a notice that needs to be included with the other notices that are typically provided at open enrollment?
So I've seen some employers including this notice, but not all are. I don't think it's a bad idea to include the notice with open enrollment. There are a lot of notices that aren't technically required to be included in those notices packets, but we often, encourage employers to include those notices. It's just sort of an additional step to make sure that you're covering yourself. So
The requirement is to post it on a public website.
Yeah, and to make it publicly available.
Mhm.
So, I don't think it's required.
Yeah.
But I think that that's one more argument that it's being made publicly available.
It doesn't hurt unless it's going to result in, millions of extra dollars in costs for you.
Or you use the wrong one.
Right.
That's true. Yes, you wouldn't want to use the wrong one.
But if you don't want to give it, no problem in not giving it.
Yeah. But yeah, just keep in mind that there is a new model notice out there. And then going to these machine readable files. So we also got similar guidance with respect to the machine readable files. So if you don't have a public website of the plan and your TPA has offered to post these machine readable files on their website, the website that would typically be used on behalf of the plan, you can rely on that for compliance as long as you've entered into a written agreement with that service provider. Self-insured plans remain responsible for non-compliance, and sponsors therefore have to ensure that the TPA is actually posting the files. Didn't address this here because it wasn't actually anything new that came out as part of this Part 55 guidance, but the machine readable files, there is the non-duplication of effort language that is similar to the language we just looked at with respect to the prescription drug reporting, where if you are in a fully insured arrangement and you enter into a written agreement with that insurer such that the insurer agrees to post the files on your behalf or on behalf of the plan, then you are able to shift liability to the insurer under a fully insured arrangement. That same relief does not apply to self-insured plans. So you still retain the liability, but you can demonstrate compliance by entering into a written agreement. I guess, this guidance leads to questions. What if you've already gone this route and you didn't enter into a written agreement? Are you not in compliance now? As Kim was discussing, we would probably argue that to the extent there are emails that represent that the TPA was going to post these links on your behalf, we could argue that that was a written agreement. But again, not a bad idea to try to get these written agreements in place. And in general, I think Julia is going to cover this in a moment, but with respect to most of the new requirements that we have addressed during this webinar series, best case practice is to try to get some contracting language in place to address the expectations, the obligations of the service providers with respect to the support that they're going to provide in connection with those requirements.
I was disappointed that those FAQs didn't address the record retention aspect. I mean, that's a question we get all the time. My vendor's posting this file, they have to update it every month. They won't save it for us. Do we need to download it? Do we need to save it? And then if we try to download it, it's gigantic size and multiple files. And I was really hoping, and we've asked the agencies multiple times, do we have to keep these records? And nothing in the guidance. So that was a little disappointing.
Yeah. Back on the contracting point, it reminded me of something that I sometimes will hear back from the vendors that say, well, our contracts contain a provision that says, in general, we'll comply with all laws. Mm-hmm. The problem with that language is typically it says something like, as your TPA will comply with all laws that apply to us as a TPA. Mm-hmm. I mean, or have language that's basically the concept. And again, it goes back to a point that I think I made at the very beginning, which is technically most of these requirements don't apply to the TPA. They apply to the plan, but we're engaging the TPA to, do certain things to help the plan satisfy these obligations. And so just be forewarned that, the compliance with all laws provisions in a contract is typically not going to be sufficient to cover these things.
Yeah. And then before I turn things over to Julia, just a comment on mental health parity. So one of our webinars in this series focused specifically on mental health parity and Addiction Equity Act, the new non-quantitative treatment limitation analysis that is required by the CAA. That requirement is in effect if you have not done a non-quantitative treatment limitation analysis or have not gone down the route to start at least trying to approach your service providers about the support that they'll provide, about the information that you can get from them. Now would be a good time to start. You can get a request from the DOL at any time seeking that comparative analysis, and the DOL is not providing a lot of time to turn that around once they make the request. This can get very difficult when seeking information. Sometimes it's a longer process than you think it might be. So start those conversations now. We are expecting additional guidance. We were kind of hoping to have that guidance by this webinar. Hasn't been released yet, but we are expecting additional guidance this year.
Okay, and last but not least, I'm going to talk about a few more things you shouldn't forget about the Consolidated Appropriations Act. So one of our earlier webinars, we spent a lot of time talking about the required fee disclosures under ERISA Section 408B2. And in a nutshell, a covered service provider who receives at least $1,000 in fees from a group health plan is required to disclose its direct and indirect compensation to that plan's fiduciaries. And the disclosure is required with respect to agreements that are entered into or amendments that are entered into on or after December 27th, 2021. So, I mean, this has been in effect almost a year now. We're seeing a lot of pushback from plan providers. The definitions in the regulations provide that this provision applies to service providers that are providing brokerage or consulting services, and those terms are very broadly defined. So from my standpoint, it seems like almost everyone, TPAs, PBMs, consultants, whatever, are providing brokerage and consulting services and should provide this fee disclosure information to the plan fiduciaries. And, you know, even if they argue that they're not, I say, what's the harm? I'm the client. I want this information. It would be helpful for me in analyzing the arrangement with the service provider and me as plan fiduciary satisfying my fiduciary obligations. It really boils down to, you know, they have to, direct compensation likely is already set forth in the agreement. It really boils down to, are you receiving indirect compensation as a result of the services you're providing to my plan? Just tell me that. And what kind of fees do I receive in the event that the services agreement is terminated? So it's really not that difficult. And I encourage anytime you're entering into one of these agreements, whether it be a non-duplication of efforts agreement or an agreement to help out with prescription drug reporting or whatever, just keep in mind that you do have to consider the fee disclosure obligations. Also, quickly coming down the pike, we have the participant self-service price comparison tool. It comes in 2 different forms. We had transparency and coverage final regulations, which were issued last year, that provide effective January 1st, 2023, that group health plans have to make available a electronic price comparison tool, and of course, paper copies upon request. And then we also had another requirement that came out of the Consolidated Appropriations Act, that effective January 1st, 2023, group health plans would be required to provide a tool either via the internet or via telephone where participants could get information relating to you know, what something is going to cost based on in-network and out-of-network providers in a specific geographic area. We had earlier FAQs, number 49, interesting, we're already up to 55. We've had a lot of FAQ guidance this year. Those FAQs came out in the fall of last year and promised that we would have additional guidance on how to reconcile these requirements with the January 1st, 2023 effective date. What is it, August 24th? We still don't have any guidance. So I think this is another thing that as you're having regular calls with your vendors to ask them about and see what they're doing in order to comply with both sets of requirements. And last, but certainly not least, air ambulance reporting. This is something I think has fallen off a lot of people's radar screen. It doesn't seem like a big deal, but March 1st or March 31st, 2023 is going to be here before you know it. And on that date, plans are required to submit claims data with regard to air ambulance services to the Department of Labor, the IRS, and Health and Human Services. This is another one of the reporting requirements that goes into effect in 2023 for the 2022 calendar year, but it renews every year. So in subsequent years, I think they did this because of leap year. So in leap year, it's due on the 31st, and thereafter it's due 90 days after the end of the plan year, which shockingly would be March 31st in every other year. In any case, another thing to put on your checklist with your TPA or providers that you're going to have assistance in completing the air ambulance claims reporting requirements for the 2022 calendar year. That brings us to the end of our allotted time. Laura, did we have any other questions we wanted to cover really quickly?
I don't think so. Just a reminder that a recording, because there were some questions, that a recording of this presentation as well as the slide deck will be sent out to everybody who registered for the program.
You're stealing my thunder.
Oh, sorry about that. I think it usually like 2 to 3 days. We just have to kind of clean up the recording and then send it out. And I don't know if we'll automatically do this with that, but there's also recordings of all of the programs that we've done in this series. Yes. and slide decks that we're happy to forward on to anyone that requests them.
Yeah, I think the email will come from Thompson Hine webinars or something like that, and it will have all 6 presentations and all 6 recordings. So, okay, so I will now read the closing remarks that Laura already talked about. Sorry. So thank you to Laura, Kim, and Beth for presenting today, and to all of you for attending our webinar. As mentioned earlier, we will send today's recorded webinar and slides to all registrants. We are also presenting a 4-part webinar series this fall that will provide employers with the latest updates and guidance on retirement plans and related issues. The webinars will be held the 2nd Wednesday of the month from noon to 1 p.m. Eastern Time, beginning September 14th and ending December 14th. You may have already received an invitation, or if not, you can register on our website under the event tab. If you have any questions that we were not able to cover today, please reach out to your Thompson Hine attorney. If you aren't currently a client, please contact me and we will discuss available options to address your needs. Thank you so much and enjoy the rest of your day.